Good morning. Thank you for having me. I'm excited to be here. I've visited your PM Pediatrics offices in Westchester, and I have some colleagues that work at some of the offices there as well. I'm going to be talking about the topic of child and adolescent psychiatry in urgent care. Obviously, it's a very broad topic. And before I get started, I wanted to see, at least for the people in the room, and I guess anyone texting in, if there's anything specific that you would be especially helpful for you. So I have more slides than we would be able to cover in the next hour. And the goal of that was to try to be able to focus on whatever is most relevant to you. So if there's anything that you've seen that you wanted to know more about, or issues that have come up over and over again that you really wanted more information on, if you could let me know. So just call out right now, and I'll write it down so I make sure I focus on those things. So for the people in the room, anything in particular that's come up in the realm of child psychiatry they had questions about? Obviously, you're also welcome to ask as I go along. Anything that people are thinking of? No. Okay. So again, if there's anything that comes up as I go, if there's something you want to know more about, just stop me and I'll slow down. Okay. So my name is Adriana Rego. I'm a child psychiatrist and I'm the medical director at the Adolescent Anxiety Day Program in QCARD in Westchester. I'm also the child psychiatrist for pediatrics in their school-based program for New York Presbyterian, and those are clinics that are in high schools and middle schools in Washington Heights, Harlem, and Marble Hill. And I teach one day a week at NYU with the undergraduate, and I teach a class called Sex Matters. It's gender and sexuality and the impact on child and adolescent mental health. But again, today I'm going to be talking about more urgent care topics. Okay. So goal for today is to talk, I'm going to touch on resources, and these are unfortunately really resources only for New York State. I know that you have locations outside of the state. And then recognizing anxiety, depression, and ADHD, medical issues to consider when someone is presenting with psychiatric symptoms, medication considerations, and then any questions or concerns that you guys have. And as we have time at the end, I'll be touching on more serious mental illness, which isn't as common in child and adolescent populations. So I just want to help make you guys aware of Project Teach in New York. I don't know if people are familiar with it. Have people heard of it here? Okay. It used to be called CAP-PC. I don't know when they changed their name. So this is the page where you can go to. It's projectteachnewyork.org. And it's for any MDs, any doctors in New York State, anywhere in your state. You can call in or video conference in to a child psychiatrist to get a consultation. And they are available from 8 to 7, Monday through Thursday, and 8 to 5 on Fridays. You can also have them come in to do trainings. And again, unfortunately, this is only for New York State, but anywhere in New York State. And it's well-trained child psychiatrists, and if you want, you can actually see who the resources are. They also have maternal mental health support, if that's something. Oh, I guess you guys don't see adults, right? Although I suppose you might see teens who are pregnant. So this is the bottom part of that first page. And you can see by region, they have different call centers. So again, this is available Monday through Friday. You can either video consult or do phone consultations with a child psychiatrist for anything that comes up. All right, so I'm putting a slide on irritability because unlike in adults, children who present with psychiatric symptoms, almost any psychiatric diagnosis in kids and adolescents can present with irritability. So unlike adults where it's more nuanced, different presentations, with kids, if they're irritable, they have something. They might have some psychiatric diagnosis, but it doesn't tell you what in particular. ADHD is one of those things that can present with irritability. It's not necessarily the most common thing that people think of. And we do find that kids who are treated with medication for ADHD often can become less irritable without any other intervention necessarily. And so this is probably the majority of what we see in child psychiatry is ADHD, and what we see a lot in contrast to adults, what adult psychiatrists say. Okay, so I'm going to try to give some case examples throughout just to hopefully make it, help make connections a little bit more between the medical and the psychiatric. So Denny was a 9-year-old boy. I was supervising a fellow who was seeing this child. He had a history of OCD and ADHD. And after years of suffering with the OCD, the parents finally agreed to medication trial and therapy. And so they began sertraline and therapy with benefit for the OCD. He was still symptomatic with the ADHD. During the course of that initial treatment, he developed a seizure disorder. And so the neurologist started Keppra. So he was started in October, and over the course of the next 2 months, the Keppra dose was titrated up. In November, Denny started to have more behavioral issues. In December, his mood started to become lower, and he had never had a history of depression. In the last week of December, over the course of a week, he had 3 suicide attempts. So this is someone who never had any history of suicidality, and at 9 years old, that's pretty rare to see kids with suicide attempts at that age. He tried to jump off playground structures, he tried to overdose, and he tried to hang himself. And so he was brought into the ED, and we had a very high suspicion that it was because of the Keppra that he had become suicidal. And so he was hospitalized, inpatient in psychiatry, taken off the Keppra, and started on a different anti-epileptic medication. And the suicidality, the low mood, and the increased behavioral problems resolved. And now years out, he hasn't had suicidality again. So we really do think it was the Keppra. So if you speak to neurologists, and according to the data, it's less than 1% of people who take Keppra that will develop suicidality. But my clinical experience as a psychiatrist is every single person I've seen on Keppra develops suicidality. So I think it's obviously the skew of who you're seeing. And sometimes we're consulted because the people on Keppra are having suicidality. But I've seen a couple of kids like Denny who have had nothing started on Keppra and become suicidal, right? So people are complicated, psychiatric issues are complicated. So obviously he had some baseline psychiatric issues, and then medical issues, and then medication complicated his presentation, right? So it's always keeping in mind, just because someone does have a psychiatric diagnosis, you always want to make sure there's not something else going on that has aggravated those symptoms. And so before I get more into ADHD, I do want to touch on suicidality, because my guess is that's probably the thing within the realm of psychiatry that people get most concerned about what to do. Would you say that's right? I'm guessing that you do get kids coming in and you're worried about this. And so I don't know for the organization what kind of screen you guys do. In a lot of primary care environments, they will do a PHQ-2, which is the first part of a screen for suicidality that the child just can fill out themselves, or you can ask the child. And if they report a yes to the questions on the PHQ-2, they can go on to fill out a PHQ-9. And so it's a pretty quick, it's a 9-question scale, and it can give you a sense of the severity of their symptoms. At Columbia, it's now being required at clinics, and all the primary care people have been trained to do the Columbia Suicide Severity Rating Scale, but you do need training to do that scale, whereas the PHQ-9, you just give the person. You don't need training for that one. And so it's a good screen for suicidality, and when I used to work at the NYU Counseling Center, and all primary care patients were screened this way, so we got a lot of referrals actually because of the screens being positive. And so a lot of people are much more comfortable coming in with somatic symptoms and getting treatment for psychiatric ones. And so I think a lot of the time people are coming in either through urgent care, through the ER, or through their PCP. One of the things we talk about with families is safety and sanitation if there's concern about suicide or somebody's been self-injuring. And so again, like if you find yourself in a situation, someone's self-injured in some way, cut themselves, burned themselves, you call the Project Teach people, and they say they don't need hospitalization, but they do need a referral. Before you send them home, one thing that you can do is ask the family to sanitize. So that for us means putting away all sharps. So it means knives, scissors, razors, pencil sharpeners, and all pills, so the kids don't have access to them. In general, my experience working in the ER and with outpatient is that whereas adults are more likely than kids to kind of plan ahead of time a suicide attempt, kids are more likely to be impulsive and in the moment, both with self-injury and suicide. So they might not be thinking about it all day, they get into an argument, they're upset about something, and in the moment they find something to do something with. So again, sanitation I think does make a big difference. Some risk factors for suicide. So there's a lot of research going on right now with various groups, and specifically a group at Harvard, on predicting imminence of attempt, right? So we can assess someone's risk of how likely they are to attempt, but right now we can't tell like if that's gonna be in a week or in a month, or we can say it's more likely in the next 3 months, but we don't know when it's gonna be. But we know the things that increase the risk. So that's what I'm gonna share with you today, and hopefully in a few years if somebody comes in to talk to you about this, they'll be able to say, just give this measure and you'll know if it's gonna happen this week. We're not there yet. Previous suicide attempts is one of the biggest risk factors. Within 3 months of an attempt, you're at higher risk. And within about 6 to 8 weeks of being discharged from an inpatient unit, you're also at higher risk. So if you got a kid coming in, you found out they were discharged a week ago, they've just self-injured, that might be somebody you send to the emergency room. right? Because their risk is much higher that first couple of months outside of the hospital. The high lethality of attempts, so high lethality would be jumping off a high structure, jumping in front of a train, I mean, the things that you can imagine, right? And using any kind of pistol, firearm. Availability of lethal means, so again, access to firearms. I don't know if you guys regularly screen when you see people to see if there's firearms in the household, but if there's any kind of psychiatric issue, it's a good question to ask, and then ask if it's secured, and then ask if they can remove it from the home until the child is doing better. Right? So in 2010, 45% of completed suicides were by firearm. So having a psychiatric disorder also increased the risk of attempts and completed suicide. Okay. There's the psychiatric. This is a list of psychiatric disorders that are associated with suicide attempts. I can go into too much specifics. When people are more agitated and depressed, they're at higher risk, and if they're reporting feeling hopeless, then they're at higher risk also. And so again, if you have someone coming in, if it's during the day, definitely I would call CAP-PC if you have any questions. If you're unclear whether you should send to the psych ER. Risk factors within families. So if there's a family history of suicide, kids have an increased risk, and that is regardless if they know there's a suicide in the family. Even people who are adopted out still have that increased risk. So it's a genetic, heritable increased risk. Research that's been done on that finds that people have the trait of pushing behavior to that extreme. So they've done research as far as like willingness to gamble, and somehow that's associated with increased suicide risk. It's also much higher in LGBTQ populations, so that's one reason to check how people identify. People who identify as lesbian, gay, or bisexual have a rate of 29% of suicide attempts, and people who identify as transgender have a rate of 41% of suicide attempts, and that goes up to 46% for trans men. So again, if you know someone is within that population, just remember that that's a really high risk factor if they also are presenting as low mood and self-injuring. Especially if you compare that to heterosexual teens, it's only a 6% rate, right? So 40 to 46% versus 6%. All right, getting back to ADHD. So I probably won't go into as much detail about, I have a number of slides on ADHD, so let me know if you want more detail or not. Otherwise, I'll go through them a little more quickly. I have some slides from a program called CASA-LEAP that was doing research on interventions for ADHD at the Psychiatric Institute at Columbia. So just as a reference, again, this is a lot of what we see in child psychiatry. About 10% of kids, according to the CASA-LEAP people, 5% across cultures, according to the DSM, have ADHD. There's about 2.5% of adults. Both boys and girls have ADHD, but it's about 3 to 1 boys to girls. And girls usually have inattentive types, so it's usually overlooked. And it runs in families, so about 50% of teens have at least one parent with ADHD. It's also associated with any kind of hypoxic events at birth, so independent of a family history. These are diagnosed. This is just the criteria for ADHD. I won't go into detail about this, but I assume that you guys then have access to the slides afterwards. Yeah, so then you can take a look at it. Yeah.
Question, I know there was some debate about the lowest age that you can diagnose. Has that number changed recently?
I mean, as far as treatment and what medications you can give, for the stimulants, for the most part, it's 6 and up. For dextrin, it's a bit lower. So theoretically, like 3 and up. I think part of what had changed is it used to be you had to be presenting with symptoms in early childhood, and now they're saying that you can start to have symptoms later on. So later on is considered still valid diagnosis. So again, just information about transmitters. So for ADHD, as far as we understand, the issue is around dopamine and norepinephrine. So it's not staying in the synapses as long, and so it's not being utilized as well by people with ADHD. So I show this picture just to give you a sense of, you'll have the information when you have the slides, but of what the difference can be in side effects between mixed amphetamine salts and methylphenidate. Because again, maybe you might be getting people coming in, taking stimulants for the first time who are having various symptoms, and they want to know if it's from the medication. So if you look, you can see, I have a pointer here, so let's see if I can get it to work. So mixed amphetamine salts and methylphenidate both inhibit the reuptake of dopamine back into the cell. And so like selective serotonin reuptake inhibitors, the dopamine can be utilized for longer when people are on medication. However, amphetamines are also taken back and are are absorbed themselves into the neuron and into the vesicles that release dopamine. And so they're leading to even higher release of dopamine than people who take mixed amphetamine salts. And probably for that reason, in kids, if you start things like Vyvanse or Adderall, they can become more agitated than if you start methylphenidate medications, right? And so it's just something to keep in mind. And usually, for my practice, I would usually start someone on methylphenidate first because of that risk of increased agitation. Something to consider if someone's just started on these medications, they bring them to the urgent care and they're like, he's like so agitated and irritated, and we just started him on medication that's supposed to help with that, and it just got worse, that is something that could happen. All right, so again, just a little bit more information on neurotransmitters. Okay. This is more FYI. This is, again, from Casa Leap, and it's education they give to the parents. Parents are always like, well, how can you have ADHD if he spends 8 hours on the weekend playing video games? When it's something that kids find entertaining, they can do it for a long period of time. Maybe that has to do with reward pathway and dopamine. But if it's something that's a little more boring, most people who are neurotypical can sit and force themselves to listen to something, even if it's not interesting, but people with ADHD can't. And so I think we're much better at diagnosing ADHD. And if you talk to older generations of people and to see if there's a history, oftentimes we didn't diagnose, but they've dropped out of college or high school. And if you ask them why, they're like, well, it was boring. They maybe had ADHD, right? Not everybody did, but that's often what people will say. So things that are approved for treatment. So the first line for ADHD are the stimulants. So again, the mixed amphetamine salts and the methylphenidate. Technically, the second line after that is an atomoxetine, which the brand name is Strattera. But practically speaking, most people will try many stimulants in combination with alpha-2 agonists before they'll try atomoxetine. The research would say that atomoxetine is effective for ADHD. Clinically speaking, I haven't seen many people who get benefit from it. It also takes many weeks to get to a dose that can be effective. Alpha-2 agonists, clonidine and guanfacine, are only FDA approved in the long-acting form, but are very commonly used in the short-acting form for ADHD. The dosing of these two can be tricky, right? So clonidine comes in 0.1 milligram dosing and up. And guanfacine is in whole milligram dosing. And so sometimes it's important to pay attention to this, because if you get confused with the dosing, you could potentially give someone like 100 times the dose of the clonidine or 10 times the dose of clonidine they should have, and obviously put them at medical risk. So always being really careful if you're covering a dosage for a few days, that you're double checking what the dosage should be, right, for that age. So other off-label uses, bupropion is used more often, I think, in adults. I haven't seen it as much in kids for ADHD. Modafinil and combined pharmacotherapy. These are older stimulants. They're giving you the brand name, probably you're familiar with. Now there's many, many more. There's more liquids that you can give. The patch, I think, is there. You can sprinkle medication on food for kids who aren't able to swallow the medication. There's different durations of medication. And so there's a lot more options now, even today. So again, this is just showing how atomoxetine acts. So adverse effects. So again, these would be things that people might be coming into urgent care for if their kid's experiencing. Decreased appetite and insomnia, most people will warn their kids about, or warn patients and parents about. The insomnia, I've given these medications to many, many people, and I saw one case that I supervised where a kid got the lowest dose of Concerta early in the morning and didn't sleep for the whole night afterwards. So there are those people that are very sensitive, and so that could be from a stimulant. It does lower the seizure threshold, but as in with the case of Denny, where he had pretty severe ADHD, the neurologist was on board with him starting a stimulant because he needed it. And that's generally the case, even when would seem sometimes to be a contraindication. The specialists usually still recommend to give it because it interferes so significantly with functioning. Risk of psychosis. So only twice have I seen somebody have psychotic symptoms with stimulants. One was when it was being abused by a college student who took Vyvanse every night for a week to stay awake. And one could say if you stay awake for a week, you might have psychotic symptoms regardless of what you take to stay awake for a week, but she did become paranoid from that. Another one was a case of a kid who was prodromal anyway, so already showing signs of psychotic disorder, and his symptoms did seem to get worse on a stimulant. But apart from that, that's not so common, just something to be aware of that it could be a risk for that. Sudden cardiac death. So obviously that's like a huge concern that we try to screen for. The majority of people who end up having sudden cardiac death have some kind of history of arrhythmias, either themselves or in their families, so we always ask. If we don't know the full family history, we do send them for a workup. So if the kid's adopted or they just don't know half the family, then we do get them further worked up and we defer to the pediatrician. So sometimes that's just an EKG, sometimes it's an EKG and an echo. Risk of abuse and diversion. So this usually is more for the college students. I feel like things changed since I've been in college. I don't remember this being so much an issue. Maybe I just wasn't aware. I did work at a college counseling center in the past, and it was known by the staff that there was like places in the library where you could go to buy stimulants. And so there is this problem with diversion. So when I have people who've been on medication for a long time and they're about to go to college, I do warn them to not tell people that they're on stimulants. You know, assuming that hopefully they're not the ones that are going to be selling it, but that potentially people could take their medication to try and sell. Because of this also risk of abuse and diversion, a lot of people do recommend giving Vyvanse because it's more the metabolite that's psychoactive and theoretically not as abusable. But again, as I just told you, one of the two people I saw who became psychotic was from abusing Vyvanse. So really, you know, you can abuse any of these stimulants. I'll also say about this that people with ADHD in general have a higher risk than the general population of abusing alcohol and drugs. Okay? And a lot of research would suggest that people who are on medication for ADHD have a lower risk than people who are not on medication for ADHD. Even people on medication still have a one would expect that taking the medication would decrease the risk of abuse of other substances. Irritability is also a side effect of the medication wears off. For some people, I do think it's because they have a decreased appetite at lunch, and so they haven't eaten, but they're actually quite hungry. And so for some kids, if the parents feed them right away, they don't get irritable. When kids do get irritable, we adjust the dose of the medication or give a longer or shorter acting medication to see if that helps with that. So again, these are old guidelines for treatment. In general, the actual practice is that people give stimulants, try various combinations of stimulants, short-acting, long-acting, along with alpha-2 agonists before they would move on to something like atomoxetine. I'm not going to go into this as much, but it's just, again, for your information, the different ways that medications are packaged. This has come up, I don't know how much you have heard about this, but it's come up in the child psychiatry world a lot. This is the structure of the brand name of Concerta. It's oral, so it's very unique in that it's osmotic in how the medication is delivered. And the issue that's come up more recently is that not all the generics are osmotic for Concerta. And so there are generics, I think there's one or two companies that make an osmotic pill for generic, but sometimes then when people switch to generic, it's not as effective as the brand name. So there are some insurance companies that will only cover the brand of it. Then there's also various formulations where you can open up a capsule and it's got these two different kinds of pellets that are short-acting and long-acting in them. Those can usually be sprinkled on food. And then there's the patch for methylphenidates. Any questions about, I realize maybe I went kind of quickly, but any questions about ADHD or any things that you've seen that you had questions about? Okay. So I didn't mention as much, but also it does can impact blood pressure and heart rate. So if you have someone coming in who's on a stimulant and you notice that they've got some kind of arrhythmia in the clinic, it's probably best to stop the stimulant. Okay. So now this is a briefer example. So Luis. 15-year-old boy presents with chest pain and palpitations. EKG and labs are normal. Multiple visits to the ER. I don't know if you have people coming into urgent care a lot with panic attacks. Yep. So Luis is actually based on somebody I saw, and it was, again, I think people are so much more comfortable with having primarily medical somatic illnesses, and so it can be very hard to then get them to actually follow up with psychiatric care. And so he was a kid like that we couldn't get him to continue to go to outpatient clinic. But you always want to make sure that you rule out all medical causes, which I'm sure you guys do, especially with anxiety disorders. There's a lot of medical illnesses that can present as anxiety. This is just a chart about how to differentiate normal fears and anxiety for young kids and adolescents versus what rises to the level of a disorder for panic, generalized anxiety disorder, and obsessive compulsive disorder. And so I won't go into detail, but again, you'll have access to this in the slides. So differential diagnosis for anxiety. So things to definitely keep in mind with anxiety disorders that you'd want to rule out. I have a patient that I'm seeing now that has anxiety and ADHD and has been found to have Graves and Hashimoto's. And so she's still in the process of evaluation to figure out what the treatment's going to be. But the only symptom she's having of the hyperthyroidism, if it's from that, is anxiety. So her blood pressure is okay, her heart rate's okay. And so the endocrinologist is still deciding what to do and following labs. But again, just keeping in mind, for some people, especially hyperthyroidism can present with psychiatric symptoms, anxiety, mania. You want to rule out other issues, of course, asthma, obstructive sleep apnea, all of these issues, right? Arrhythmias, anaphylaxis. And again, somebody can come in 10 times and it's just a panic attack, and the 11th time it might be something else. It's just always making sure there's nothing medically going on. Sorry, I didn't make the animation on the slide. So again, workup to rule out all of these illnesses. And keeping in mind that any underlying medical issue will be aggravated by anxiety. So symptoms will get worse. It's not that they're imaginary, it does make pain feel more painful when you're more focused on it, right? You can distract from it, you can feel a bit better, but again, anxiety does worsen symptoms of actual illnesses. And so I think there's huge overlap between GI disorders and anxiety, and so for some illnesses, giving a medication for anxiety does help with the GI illness. And so this, again, I don't know how much time you guys have for these things, but one way to increase or decrease your suspicion of anxiety is to get a family history. Many of the anxiety disorders are highly heritable, especially OCD. And then screening tools. So really easy one is the GAD-7. You can Google it. It's just 7 questions. It is available online for free. And again, it just gives you a sense of how much there's anxiety playing into whatever is going on with the kid. And they can fill it out themselves. The SCARED is a much longer questionnaire, and you have to actually do math to figure out what diagnosis they have. So I feel like the GAD-7 is great because it's quick and easy. And so again, if you've ruled out all anxiety, all possible medical issues, then that's appropriate to refer to psychiatry. Usually anxiety disorders aren't life-threatening, and so it wouldn't be necessarily something to send somebody to the ER for or the psych ER for, but to refer them for outpatient, especially if they're coming in over and over for panic attacks. Okay, so medications for anxiety disorders. All right, so these are the same medications that we give for depression, and so I'm going to touch on the issues around the medications for both these illnesses. I put the brand and the generic name. Adverse effects. So most common side effects for these medications happen within the first few days, so usually 3 days, and will go away. So headache and nausea are the most common thing that I've seen when doses are started really low. People don't have those, but again, they usually go away after a few days. Sexual side effects, especially in adults, is one of the big reasons people stop taking the medications, and those tend to persist, unfortunately. Increased risk of bleeding. So something to keep in mind if you're going to send someone for a procedure and they're on an SSRI is that they should, usually we tell people to stop taking the SSRI a couple of days before and for a couple of days after, because it does impede platelets from clotting, impedes platelet functioning. The black box warning. So I imagine you guys have heard about this because you're seeing kids, but so under the age of 25, research has shown that there's an a risk of increased suicidality in kids who take SSRIs within the first 6 to 8 weeks after the last adjustment of the dose. So what the research showed is that in placebo, people have an increased risk of suicidality of about 1%, and with the SSRI, it's 2%. So it's a pretty rare side effect, but obviously a really concerning one, and that is why people are usually followed pretty frequently after starting these medications. Right when that study came out, people started prescribing a bit less and suicide rates went up. So again, it's a great medication for improving suicidality and depression. Oh, did I do something? Why did that just, that was weird. Okay. For suicidality, it's very, very effective medications. And so just to keep in mind, so it increases thoughts about suicide or reporting suicidality, not acting on it. So people don't have more suicide attempts, it's just reporting it more. There's different ideas about why that might be. One is that some people, when they're very depressed, they're neurovegetative, so they're in bed all day, they're not talking. The idea being that as they get to feel better, they're reporting things that have already been going on. And that I've certainly seen that as kids start to get better and less anxious and depressed, they start telling us about the thoughts they've had for months that they weren't reporting. Things to watch out for that are more medical, serotonin syndrome. So if you're on a combination of SSRIs or medications that, SSRIs plus other medications that might increase serotonin, you have to watch out for this. So I usually warn people, I've never seen a kid or adolescent get serotonin. So you look for sweating, neck stiffness, fever, GI symptoms, tachycardia, hypertension, confusion, tremor, without like a known source of infection. There's also a risk of seizures. So again, I've never seen someone get a seizure from these medications, from SSRIs or SNRIs, without already having a seizure disorder. I did have a teen recently that had been worked up for seizures in the past and been found, they didn't find anything on EEG, but it turns out she hadn't reported childhood events that were seizures. And as she started on CYMBALTA, maybe from the medication or not, she started to have seizures. And so again, she has an underlying seizure disorder. We always ask about that when we give medications. And then hypomania or mania. So if someone develops hypomania or mania, it doesn't necessarily mean that on a medication like this, it doesn't necessarily mean that they have bipolar disorder, but you would want to stop the medication if they become manic. So this is more specifics about each medication. Fluoxetine tends to be the one that interacts with the most other medications. So always check if you have someone on fluoxetine that you're giving medication to check for interactions. It has the longest half-life. The biggest risk is a prolonged QT. So that's also people take too many pills. That's the thing you'd most be wanting to watch out for in checking EKGs, either by accident or on purpose. Fluoxetine, because it has such a long half-life, is also given to people when they have problems coming off of other SSRIs for discontinuation. Sertraline, so I should say, so fluoxetine, there's the most research on. It's the oldest one in this class, one of the oldest ones in this class, and it's the only one approved both for OCD and major depressive disorder in kids and adolescents. Sertraline is only approved for OCD in kids and adolescents. It's 12 and up, just double check the age. And again, with all of them, there's a risk of arrhythmias if you take too much. Escitalopram and citalopram. So the risk with this is higher. This is Celexa and Lexapro. Only escitalopram is approved in kids, and that's from 12 and up for major depressive disorder. It was found maybe 8 years ago that high doses above 40 milligrams of citalopram could lead to torsades or prolonged QT. And so that if you were to go above that dosage, you should get serial EKGs, basically. And so I think it has led to people no longer prescribing over 40 milligrams of citalopram. Escitalopram is a D-isomer of citalopram, and so there is some also risk above the dose of 20 milligrams. So just something to keep in mind if you have somebody coming in at 25 reporting like palpitations or something, to double check. Fluoxetine is an SNRI and is now approved for GADs. I'm sorry, I didn't put there. GAD in kids as well. So generalized anxiety disorder. This is the medication the person I put them on that developed seizures, or had underlying seizures that then had a seizure on this. Discontinuation reaction. So people don't necessarily get what we would call withdrawal from these medications, but if they stop abruptly without a taper, they can develop nausea, diarrhea. Brain zaps is a pretty specific term that people use for venlafaxine, so that's Effexor. And it's this people describe it as like kind of like electricity going through your brain. If you miss even one dose of the medication, people will experience that. So in one way, it's a good way to increase compliance, but obviously like really unpleasant reaction. I don't prescribe venlafaxine as much anymore. There was a review article in Lancet that came out a couple years ago that showed that of the SSRIs and the SNRIs, it increased suicidality more than all of the other ones. So I just don't give it anymore to adolescents. Also, people can get headache and irritability. So if people are presenting with these symptoms and they've just come off of one of these SSRIs, that might be why. So things to consider, and I don't know how much you have to intervene for agitated kids in your setting, in the urgent care setting, like how much this comes up. But certainly with kids presenting with reports of agitation, things to consider with kids with traumatic brain injury, autism spectrum disorders, intellectual disability, if they've had some kind of stroke for some reason, or just kids, young kids, benzodiazepines and antihistamines can be disinhibiting. So even though we give those usually for adults to calm them down when they're agitated, for kids they can have a paradoxical reaction where they become much more agitated and can't sleep. So just something to keep in mind if you do ever give medication in your setting to calm people down, that these are not good ideas for this patient population. Things that you can consider for this patient population are beta blockers if you were to need to give something in the setting.
Before,
Sorry,
just
yes.
real quick, do you have a non-medicinal approach to panic attack treatment?
Sure. Yeah, I mean,
Acute care.
yeah, of course. So I don't know how much you can have like fidget stuff or like stress balls and things like that. Those are useful. I can teach you guys a pretty simple grounding exercise. If you have like magazines or I think when I've gone to PMPDX, you have like photos or stuff on the wall. Yeah. So if you have somebody stand up and just ask them to describe or imagine themselves in the situation, that sometimes helps. Again, it just depends how much time you have. Like I could teach you guys any kind of mindfulness exercise. If you guys do mindfulness, I feel like a lot of people do mindfulness now. That can be effective for panic attacks. Yeah, I mean, distraction, getting them out of their head are the big things. So simple mindfulness would be something like if you, it depends how agitated they are. So one thing would be like stand up, describe, if you have like a picture of a beach scene and they're like going to the beach, imagine yourself in this scene. I want you to describe to me with the 5 senses what you're experiencing. What do you smell? What do you see? What do you feel on your skin? What do you hear? And just have them put themselves into that picture. Grounding, and again, like other mindfulness can just be giving them a candy and asking them to describe what it looks like, what it smells like, what it feels like in their mouth. Again, is to kind of pull them out of their heads. A simple grounding exercise. I have time. So I could do a simple grounding exercise with you guys right now. If I could have a volunteer to answer very easy questions. Great. What's your name? Jody? Okay. So, and if you guys try to do it along with Jody, it's not going to be as effective, obviously, because it's not one-on-one, I think. But so, Jody, I want you to tell me 3 things that you can hear right now. Should be easy. 3 things you can hear right now.
Drilled. You're talking, and I can hear typing on the computer.
Okay. I want you to tell me 3 things that you can see right now.
I see trees. I see chairs. Lights.
I want you to tell me 3 things you can touch, and I want you to touch them.
There's a table. There's my pen. There's my cup.
Okay. And so you can do that a few times with people, and again, it's to get people out of their heads. So panic attacks are often driven by kind of catastrophic thoughts or escalating thoughts that people are having. And the idea is to get them back into the room, back into the present, back into their bodies. And so for some people, depending how agitated they are, I will try a few things. I'll try the picture, I'll try the grounding, I'll try giving them candy or something. There's a lot of reasons why people have panic attacks. If it's a panic disorder, we used to say that they're out of the blue, but usually there is some kind of trigger. A lot of times when we see panic, it has to do with trauma. People have been triggered. And so grounding exercise, the one I just did, is very specific for trauma. But it would work with any kind of panic attack. Okay. So severe mental illness. So this is rarer in children and adolescents. So especially for things like psychosis, you absolutely have to rule out a medical reason because this is not common in people under 18 or so, 17, 18. So this is a clinical case that I saw. This is a 12-year-old Dominican girl who presented to the emergency department in October, a number of years ago now, for 3 days of not making sense. So sudden onset is always to be a concern that there's something medical going on. As a lot of things that are more psychiatric are going to be gradual. Not answering questions appropriately according to the school. They did basic labs, a head CT. So again, anytime someone is, altered mental status or there's concern about psychosis for an episode, we always get some kind of head scan. And an EEG were all within normal limits. She was cleared by neurology to psychiatry. They did draw ANA levels, but they were pending on discharge. So she was transferred, she was hospitalized psychiatrically, stabilized, transferred to the outpatient clinic, had difficulties for compliance due to various psychosocial stressors, and ended up back in the ER in November with psychotic symptoms and aggressive behavior. She was hospitalized again and discharged again, and finally, after all of this, it was like 2 months, there was finally follow-up that the lab was able to connect to a practitioner, and she was found to have lupus, and that she had had a lupus flare, and that was why she was presenting with these psychiatric symptoms. So something, again, especially when you're looking at kids with a sudden onset of psychiatric symptoms, you always want to consider something medical. And so even if these symptoms are medically caused, you do treat it with psychiatric medications, but you have to treat the underlying medical illness, right? These psychiatric symptoms would never resolve if the lupus hadn't also been treated eventually. So again, psychosis can occur in 5% of patients with lupus. One study showed as high as 61%. The other thing I would bring up just around psychosis and worsening with treatment, with medical issues and treatment of medical issues is the thing that I've seen a lot is kids with, especially when I was working more in Washington Heights, kids with ADHD who also have asthma that are then given steroids because of the asthma exacerbation, who then get much more agitated and aggressive. And I actually had one kid who started having auditory hallucinations from being put on the steroids. So we would always try to warn the mom to tell the pediatricians, especially when he was hospitalized for the asthma, that this would happen, right? And it's not to say not to give the steroids, but just to be mindful that it can cause much severe worsening of psychiatric symptoms. Sorry, so along the lines also of medical issues that present with psychiatric symptoms, I had a colleague who had someone who presented with sudden onset OCD, decreased sexual interest in a young adult male, who ended up having a pituitary tumor. So again, any kind of sudden onset of symptoms, you always want to rule out medical tumors. These are medications that are approved for mania in kids and adolescents. So you can see that lithium is the only mood stabilizer that's approved. It is the most effective treatment for mania, but it's not a benign medication. The antipsychotics now are approved for treatment of mania as well as mood stabilization, as a kind of maintenance treatment. Things to watch out for with lithium especially. If you know someone is on lithium and they're coming in for any kind of medical issue, you should always get a lithium level. There's a very narrow therapeutic window for lithium, and toxicity can lead to really severe consequences. It's approved for kids 12 and older. Any kind of dehydration, if you have somebody on lithium who's coming in with diarrhea or vomiting, you should check the lithium level just to make sure it's not going up because of the dehydration. It's clear through the kidney. Levels above 1.5 is a high risk of toxicity. So people can have, even at therapeutic levels, people can have tremor, acne, weight gain, hypothyroidism. It can impact kidney function as people are on it longer, arrhythmias. It's a pretty hard, it can be a difficult medication to tolerate, and is probably a big part of why people who are bipolar come off of their medication. When it's in toxic levels, you're looking for myoclonic jerks, lethargy, confusion, fasciculations, prolonged QTC. Other medications other things to think about with medications for bipolar disorder, with Depakote, you want to watch out for thrombocytopenia and hepatotoxicity. With the atypical antipsychotics, you can get metabolic syndrome, so we monitor weight and labs every 3 months at the beginning. And also they do lower the seizures threshold. Lamotrigine, the biggest thing would be the Stevens-Johnson. So that's the only reason I've seen someone to stop lamotrigine abruptly. In general, it's a really well-tolerated medication. Okay, so these are differential diagnoses for psychosis and things you'd want to work up if somebody's presenting, especially with acute onset of psychotic symptoms. And these are the medications that are approved for early onset schizophrenia, so that's under 18 would be considered early onset. And again, so the adverse reactions, metabolic syndrome. Galactorrhea is associated mostly with risperidone, so I don't know if you guys have seen anyone come in, like adolescent with galactorrhea. It's pretty aversive. They also can have gynecomastia. Usually they don't want to stay on the medication if they're getting that. Tardive dyskinesia are abnormal movements that are with antipsychotics, usually after a longer time on them than a kid would be able to be on it. higher risk of that with older antipsychotics like Haldol, and generally you have to come off the medication to try to remedy that. Dystonic reactions, this, I don't know how much you would see this versus people going to the emergency room, but ocular gyrocrisis, that's where eyes are rolling up involuntarily in the head. And if it's that acute, you can give, are you able to give IM medications? You are. So you give benztropine or diphenhydramine for that acutely. Okay. And then, I'm sure there's anything else. Yeah, any questions about, I realized it was like a lot of things that I went through kind of quickly, but any questions about anything I didn't mention or things that I did mention that people are wondering about? Yes.
I was wondering if you can comment on the resources we have available in Long Island for counseling services, or if a teenager wants to call anonymously for help.
Oh, sorry, I should have put that number on. So the number,
Here in New York City too.
yeah, so the number I'd recommend in New York would be 1-800-273-8255. So it's 1-800-273-TALK. I think that's now what they put on all the TV shows at the end. It's a crisis line that the suicide researchers at Columbia have worked with. So very well-trained people. I've had kids call, and basically they do coping skills with the kids to try to help them get through whatever's going on. You know, 273-TALK, yeah. Theoretically, it's for LGBTQ populations, but the Trevor Project, if you go to their website, they have a phone line, they have a G-chat, they have a text line that you can reach out to. I don't think they're going to ask if people are LGBTQ before they will give a counseling. So again, that's a great resource. On Long Island, you know, Long Island is tough because it's huge and there's not that many places. But obviously Stony Brook has a good child psychiatry department. LIJ, which is now, I guess, Northwell, the whole thing. And they have an inpatient, both places have inpatient units. In the city, one thing I will suggest is if you think someone needs to be hospitalized, to send them to an ER that's connected, that's in a hospital that has actually beds. This is true for, I guess, anyone anywhere in the country. If you think they need hospitalization, send them to a hospital that has child and adolescent beds in it. Because otherwise, that ER is going to have to try to get them into another hospital, and the hospitals are always have to give priority to the people in their own emergency rooms, right? So again, so if you can direct them to a hospital that has inpatient beds to the emergency room, they're going to have much more luck at getting in more quickly. There's a lot of inpatient units have closed. There's a real shortage of beds. And unfortunately, in a lot of places, people end up in the emergency room waiting for days. So again, if you can connect them to a hospital that has inpatient beds, they're going to be more likely to not sit in the emergency room. Unfortunately, the longer people sit in the emergency room, the less willing they usually are to be hospitalized. Something to keep in mind, especially in New York City, is that all city hospitals get priority at Bellevue. So if somebody's at a city hospital, Bellevue has to prioritize them. So whether it's like Jacoby or Elmhurst, I think is one. So any of those hospitals are going to be prioritized by Bellevue, but that also means if you are in a private hospital, ER, you're going to be low man on the totem pole to get into somewhere like Bellevue. The other thing I would say is it's good to know about, from whatever region you're in, is about mobile crisis. So in Westchester, I think it's through St. Vincent's is a program, but if you Google mobile crisis and put the name of your county, there, I think probably in New York, certainly in this area, Long Island, Westchester, and Manhattan, there's that resource. And so they're usually available 24 hours a day, and will go in within 24 hours of getting a call or a referral into the home and evaluate the person if you're worried. And so you can give information to families also if they're concerned and need a resource of something, if they're worried that their kid's going to decompensate, but right now they're doing okay, that's also a great resource. And I'm trying to think, I think in Manhattan it might be 1-800-Lifeline, but I'll double check that and let you know. But if you Google mobile crisis for your area, it should come up with a number. What I would say is for kids who are on the spectrum, Autism Speaks is a good resource also for finding places for treatment. And probably Project Teach would also be able to help you locate places to get the child into treatment. And again, they're for all of New York State. Autism Speaks is probably for the entire country. There are very few places that have the resources to care for someone who's on the spectrum on the inpatient psychiatry unit. So that's also, unfortunately, a place where we're very limited in our resources. Any other questions?
Thank you very much.
Okay, sure.